Hello, everyone, and thank you for coming to the TEPI Infection Prevention 208 Contact Trace lecture. I just want to first take a moment to thank you all for being able to switch platforms. This morning we're having some technical difficulties on our previous platform that we've given the previous modules through, and then switching through this new platform on Teams. Going forward, our next lecture, 209 and 210, will be on the Teams platform. So be on the lookout for more information either on social media, our TEPI webpage, or through email communication about how to re-register and access the link for the upcoming modules. So if you've previously registered for 209 and 210, you will have to re-register just like you did for today's module. We apologize for the inconvenience, but we are experiencing some technical difficulties. So I just want to say thank you for your flexibility, and I'll repeat that at the end of the lecture. So thank you for coming for Infection Prevention Module 208, Contact Trace. This is a brief overview of the contact tracing during an outbreak or an exposure event, specifically in a healthcare facility, which really focuses on strategies to reduce transmission, ensure safety for patients and staff. Just like previous modules, or if you're new here to the TEPI IPC series, the first part of the lecture will be straight lecturing. We'll give you some background information, and then we will go into a learning activity. I do ask that all questions wait until the learning activity, and then you'll have a chance before we start the activity, which is just a 10-question example, and we'll work through a case example just like we did in Module 207. If for returning attendees. And then at the end of the learning activity, I'll open it up for overall questions as well. This is recorded and will be posted on our TEPI YouTube channel along with the slides. You will have access to the slides within about a week through email correspondence, which also will contain a link to today's recording. So before I get into the module, I just want to briefly give you a little overview of what TEPI is. TEPI is the Texas Epidemic Public Health Institute, which is housed here at UT Health School Public Health here in Houston, Texas. And our goal at the TEPI organization is to really keep Texas safe and Texans safe and our economy strong by helping create new ways to prepare ourselves for the next infectious disease outbreak or pandemic. So I am today's presenter. My name is Dr. Kayla Rush. I am an infection prevention practitioner who is certified in infection prevention and control, public health, and healthcare accreditation process. And I also have a PhD in epidemiology, which my whole research focuses on infection prevention and control education and training processes. Today's learning objectives for this specific module will be to just describe and explain what contact tracing is, discuss how to recognize when a contact trace needs to be conducted, and then discuss a case example. This module has been approved for continuing education for certified public health individuals or anyone that hold a CPH, or if you are a certified infection preventionist and hold a CIC, you can complete the continuing education survey and evaluation to submit and obtain your certificate for continuing education. And at the end of the lecture, there will be a slide with details how to complete those actions. So let's begin. Let's talk about contact trace. So before we start the lecture, I just want to give some brief introduction to some terminology. If you're new to contact tracing, a lot of times we use the words case definition. We talk about occupational exposure, which in healthcare facilities, we specifically look at infectious material, but you can also do it for chemical compounds if you're worried about other chemical exposures. If you're in the industrial hygiene or industrial health or OC health, You can conduct a contact trace with different parameters, but we're specifically focusing on today's lecture on healthcare facilities, specifically looking at infectious material. Also, determining the difference between a cluster and an outbreak event. And then what is deemed as a close contact. As I'll mention in the lecture, there is different definitions on what a close contact is based on your specific pathogen. So you need to keep that in mind. The time, the distance that you are deemed within close contact and what that means will change with the pathogen that you are specifically working up. But it is overall the general terminology definition is anyone with close proximity for an infected person, therefore has a high risk of becoming infected. Your index case is known as your index case, or your subject 0 is the person that starts the spread, and then quarantine, as we know, is different infection prevention and control measures that we can implement to prevent the spread of infectious disease or pathogen. So as I've alluded to, contact tracing is the process of identifying people who have recently been in contact or exposed with someone that has a infectious pathogen that they're harboring. They're either incubating, they're actively sick, they can be symptomatic, asymptomatic. And this process really helps quickly identify, assess, and manage those who have been exposed and to prevent further transmission. So this is a process that after we know that an infectious individual has been in close proximity to individuals that there might be possible risk of transmission, this is the process and steps of how to identify who has been at risk and what are the next steps to do to prevent the spread. We usually conduct contact traces during outbreak events or exposure events. For anyone who has been potentially exposed, it should be followed up with to confirm symptomology, their clinical symptoms, how they're overall feeling going forward. The goal of contact tracing is to identify, reduce, and eliminate the spread. So it's identifying who is potentially infectious, who's maybe suspect of being infectious, and then putting infection prevention and control measures in place to prevent the spread. You can conduct contact tracing, or contact tracing should be conducted when infection prevention measures have not been initiated or there's been a breach in infection prevention barriers, PPE, processes, HVAC systems, when handling infectious material or infectious patient. Anytime there's any breaches or lack of infection prevention protocols initiated, you'll want to conduct this to, again, rapidly identify who has been potentially exposed and reduce the transmission. This is a systematic process that involves tracing an infected pathogen location and individuals in healthcare settings that involves both staff, so healthcare workers, and patients that may have come into contact with the index case or patient 0 or the original origin of the infectious material. Even though it is a systematic process, the definitions and sometimes the workup might change based on the specific pathogen and situation that you're in, along with if this has been a breach in infection prevention and control barriers, or if there has been a lack of infection prevention. But these 9 steps that we'll talk about today should be used and implemented throughout the process, but there will be a variation based on what specific pathogen or what type of patient or event you are working with too. So please keep that in mind. And one main thing that you want to really be mindful of when you're doing a contact trace or an outbreak investigation is really remembering that epidemiological triad of infectious disease, and that's that dynamic relationship between our host, our agent, and our environment. So what specific pathogen, who's our host? Is it people? Is it patients? Is it healthcare workers? Is it animals in the environment? Where are we that this outbreak or potential exposure has occurred? That will all go into how you're going to be working up and conducting your contact trace. So if you recall from last module 207 that was called outbreak, we went over in detail the 11 steps for the initial part of the outbreak investigation and then the post 5 steps of the follow-up of an outbreak investigation. So when you're conducting an outbreak investigation, you will conduct a contact trace simultaneously around step 3 when you're looking at verifying the diagnosis. So in an outbreak investigation, you will specifically look at, confirming the presence of an outbreak, identifying the outbreak investigation team, and then verifying the diagnosis. So on step 3, when you get that confirmation result saying that it is confirmed either on serology, PCR, culture assay, microscopic, histology, pathology, whatever means of laboratory diagnosis that you have confirmed and verified that it is this pathogen, the best recommendation is to split your staff into one side is doing the outbreak investigation, so continuing with these 11 steps while one person or a team of people are doing a contact trace and really identifying who's been potentially exposed, getting them tested, getting them treatment, putting them in isolation. So these two processes are done simultaneously. So you need to review module 207, what we talked about in the outbreak investigation. That is posted on the TEPI YouTube channel. You can go to the main page and review it, and you'll also have access to the slides as well. So as I mentioned, this is a standardized workflow, and there's 9 specific steps that you will conduct during a contact trace. And the first step is always to identify and confirm the index patient or the point source. So that is, we have confirmed that step 3 of the outbreak investigation is now step 1 of the contact trace. You have that test result confirming this is pathogen X. So you know that there is a problem and in the outbreak that you're trying to see where infection prevention opportunities have been lacking and identify opportunities for improvement. Next, you will want to develop or review your case definition, including patient symptomology and timelines. And this is important to know that when you are tracing patients, when you go to interview them later, which we'll talk about in a few slides, you know what symptoms to ask them if they are experiencing them. Also knowing their timeline, like when they were around that patient, that will kind of dictate into your step 3, which is your incubation period, your route of transition of infectious pathogen, and exposure criteria. So knowing 2 and 3 is really crucial because maybe the person that you are interviewing saw the infectious patient 5 days ago, but the incubation period is only 48 hours before symptom onset, so they haven't been exposed. You might identify them, but based on the criteria of exposure on incubation, route of transmission, and exposure criteria for that specific pathogen, you can identify and eliminate individuals that are outside of those parameters. So really having robust information of the pathogen, how it's transmitted, what's the exposure criteria, and how long is it incubated? Is it, asymptomatic for 48 hours, which we saw with COVID? Is it symptomatic right away? Is there a latency period with that, but it's still infectious transmission going on, or not? And then also knowing what route of transmission for the pathogen, if it's, within 6 feet, if it's within 1 feet, it's in the same room, it's, having that close contact, that physical touch, sharing devices, that all will go into ruling out if people have been exposed or not. And therefore, then you are testing and providing treatment to the appropriate identified individuals that have the highest risk. So as I kind of alluded to, determining exposure criteria can be very challenging because of multiple things go into it. It's based on the transmission of the pathogen, the vaccination status, if you're fully covered or not, what PPE that you are wearing, all goes into the CDC guidelines of their specific definitions if they have been exposed or not. and vaccination coverage as well. It can also be challenging because when you're interviewing with patients or people that have been potentially exposed to the infectious person or pathogen, you might encounter some recall bias, which they can't really remember when they were around them. Was it a day ago? Was it 2 weeks ago? Sometimes that happens that originally when you first interview someone, they said, oh, I was with the person 2 days ago. And then later when you're going through more details within the interview, it was, oh, actually that was a month ago. So just making sure that you are asking clear, concise questions and that you feel really confident in the answer that's been given. And you're also going to have missing data. Sometimes individuals cannot recall how close they were, how long that they were with them, if they shared any devices with them. For example, if they went out to dinner with an individual, did they share any food? Did they share any drinks, or did they have their own separate? There was no sharing of utensils. So making sure that you're leading on the side of caution, and that's up to you to make the determination of with missing data and recall bias also still then determine, does this patient or individual need to be tested, or do you think that the risk is minimal or very low and they don't need to be tested and followed up during the time? As I mentioned, close contact criteria is pathogen dependent. For this example, we're going to talk about C. auris again, especially that module 207 talked about C. auris, and then also in module 206, emerging pathogens, we talked about C. auris. So the C. auris close contact criteria that we're going to be using is in the same environment, that's in this shared same environment, such as in a healthcare or hospital setting, that you're in the same room, using the same bathroom, same living quarters, you're sharing equipment, maybe you share the same blood pressure cup, hopefully not, or you have physical contact, you're hugging, touching, physical contact with that individual for that specific one. As I mentioned before, for example, COVID has a different criteria definition, Ebola has a different, Mpox has different, so making sure that you're using that specific pathogen's close contact definition when you are doing your workups. So then our next step is we have identified our case definition, we know our exposure criteria, our incubation criteria. Then the next thing is to establish or determine when infection prevention control measures were implemented. So when were things done appropriately and when were things not? When were they on isolation? When were they in a single room compared to when those things weren't? Also, if you are doing a breach in infection prevention measures, say that you had PPE, but later you found out your PPE wasn't effective. When was that time? So you'll use that as step 4. And then after you have that information, then you will go to step 5, which is tracing the physical location where the patient was during the time where IPC measures were not implemented. So you are going to physically track or trace, like a map, where the patient was, all the units, all the areas, all the people that they have come into contact when the infection prevention and control measures were not implemented or there was a breach in them. And then you will have a lot of data, and specifically in healthcare facilities, you need to trace healthcare staff that cared for the patient and also other patients that might have come into contact with this individual. So that means if they've been in a public room, a 2-bed, or if it's a nursing home facility, if it's in a 4-bed suite area, if they've been in your ED, in the lobby, you'll need to know what other patients were around them to get them tested and identified as potentially exposed or not, and you will make that determination during the interview process. Then in step 6, you will determine the patients and staff that were in close contact with them when IPC measures weren't established and that close contact criteria for exposure has been met, and that is when you interview the patient. So before that, then you want to gather the information and what questions you are going to be asking these individuals. So the difference is with 6, you are now pulling the data of what patients and staff have been in contact. You have not interviewed them, but you're just you're gathering your list of data of who potentially you now need to interview to ask to make that determination. Were they in close contact? And what PPE was worn during that close contact, and if vaccination status is applicable to them. For this definition, for this case example, we are using C. auris, so there is no vaccine against C. auris, so that will not come into play. But in other pathogens, since influenza, RSV, COVID, vaccination status will come into play. So now that you have pulled your data, you have it in 2 groups. You have staff that have been potentially exposed that you need to interview, and you have patients that have been potentially exposed that you need to interview. Now you are going to gather the questions that you need to ask them during your interview process. So some great questions is what date, time that you met the infectious individual. Were you in close contact? Give them the definition of close contact. Do you have any PPE on? What was the duration of that time? What was the frequency during that period? So if there's a few days where infection prevention and control measures were not implemented, ask them during that timeline, was this a one-time encounter? Was this a multiple-time encounter? Say it's a family member that came to visit an individual that was infected with C. auris, 3 out of the 4 days infection prevention and control measures weren't implemented. You want to ask that question: frequency, duration, close contact, any symptoms that they are experiencing, and let them call so that you don't let them recall that information and not give recall bias, because you don't want to ask too many leading questions to get some false answers. But if they truly are stuck with symptomology, definitely ask them, like, are you experiencing XYZ based on the pathogen that they have been exposed to? Then for step 8, you will conduct the interviews. You'll go down your list, you'll ask the questions, you'll determine if close contact exposure criteria has been met. Then you will determine immediate and long-term recommendations and plans that usually involves testing them, providing them care, if they should quarantine, putting on isolation, all of those measures for step 9. So before you get to the part where you're interviewing them, because when you are interviewing them, you are going to provide them with next steps. You want to make sure that you know what the next steps are. Are you offering them testing for these individuals that have been exposed? Is this something that your organization's doing? Does public health need to be doing this? Who is paying for this? Is it the organization or the individual, or is it a third party? Also, if you are doing this at your facility, check with lab and operationally that you have these materials to do testing, because you might have to test a lot of people, and maybe the lab workflow did not really put that, it's not on their radar. So definitely for laboratory flow, you'll need to talk to them. And then also when you're testing healthcare workers, you want to partner with your occupational health director, manager, whoever, to make sure that you are on the same plan of, like, we are going to offer, these are the criteria for healthcare workers. This is the exposure criteria that have been met. We are now offering them testing, and then occupational health is giving them recommendations about quarantine, if they can work. Can they work while the test is pending? Do they have to be off work? Occupational health will do all of that. Sometimes during contact tracing, occupational health will talk to all the employees, since that's very protected data, and PHI. Sometimes they will have you do it. So when there's an event, make sure that you are talking with your occupational health partners to identify who's doing what. Usually they do staff, and infection prevention does patients, but depending on your facility workflow staffing, that might be different. So during an outbreak event, there's contact tracing being done. Now we need to do testing of staff. Get with them to make sure that this is approved, this is appropriate, we know who's putting in the orders for this testing. Are they getting it done at the facility, or are they going to have to go somewhere else? These are all questions and conversations you should have before you call a staff member so that you can provide them with clear and concise information. The next, you're going to do isolation and quarantine on the patient side. It's really easy to put them on isolation when they're already in the facility, pending their results. And then you'll also implement recommendations based on public health as well. So how you can do this is that most EMR systems or surveillance systems, EMR is your electronic medical record, or if you have a third-party surveillance system, they have the tech ability to run a contact trace for a specific patient, which allows you to bed trace the patient. You can see where they were in your facility, all the units that they visited. And if you're not sure if you have this ability, you can definitely reach out to your IT or bioinformatics person on your EMR system or your third-party surveillance system, and they'll be able to walk you through that. But this will pull a bunch of data for you to see who all accessed the patient's chart. So this is a digital footprint, but you also need to then confirm that there was no one else that entered that area or had contact with that patient. So you'll still need to follow up with those specific units and talk to them and confirm that no one else was in that room. This is also really great because it'll pull data on what patients were room next to them, what came after them, where they were in the ED, in their rooms, if they had a double occupant room or if they had a single occupant room. So as I mentioned, the EMR system doesn't include everyone, so you're still going to have to circle back with the unit to confirm that no one else went into that room and talked to the staff. And as I mentioned, if you don't know how to do this, or if your system has the capability, contact your facility's IT or bioinformatics department. They should be able to walk you through this step. If your facility does not have an EMR system or a third-party surveillance system, you will have to do this by hand. So you physically trace where the patient is. So you'll go to the unit that the patient currently is, get the list of names, talk to the unit manager, look at assignment, and then work your way back and go to all the different departments, all the different units that the patient was in, and circle up with those staff and ask them who had this patient, to be able then to interview them to get your list of names. So what you'll see at the end of it is kind of this web design, as you've seen some of the other graphics, that you have your index case, you have other infected individuals, you have suspect individuals that maybe have been infected but not showing symptomology, and then you'll see kind of how it's spread throughout your facility. So next, when you are conducting your contact trace interviews, there's 4 main ways to conduct it. First, after you have your list of individuals, I would start either do all the patients and someone does all the staff, or start with complete all one group and then move on to all the other group, because you will have to ask them different information. So be consistent. If you start with staff, do all the staff first and then do the patients, or do all the patients and then do staff. So how you want to conduct your interviews, you always want to first introduce yourself. Say, hi, I'm, for example, for me, I would say, hi, I'm Dr. Kayla Rush. I'm an infection preventionist here at this facility. There has been a potential exposure event. Is it a good time to talk to you? I have a few questions. And if they say yes, then you'll continue and then explain, say, I'm following up. There's been a potential outbreak or exposure event at the facility. I need to ask you a couple questions about your involvement with patient X. So then next, you'll be gathering information and listening. You'll ask about the individual's demographic, contact information, all the things on the screen. So you'll ask them, their name, their date of birth. You want to collect that, a good callback number, in case you need to get more information from them. That is always key, is getting a callback number. Collect information about the exposure, ask them where they were, how long they were, what PPE were they worn, if they are vaccinated which for our Candida or example, that's not applicable. And then if they've had close contact with the other individuals too, because then you'll have to get that information and go forward. Or you might just want to wait until you test them, because in their bubble, they're the index patient as well. So definitely thinking through it of what's going on. And then next you will provide recommendations, which is then telling them, oh, we recommend you get tested. You can come here to get tested, or go to this third-party level of testing. It'll be covered by the organization, or public, the local public health department. Or if they want to get tested, they'll have to cover that cost. What type of isolation recommendations, i.e. if they need to stay at home, if you need to implement certain infection prevention practices, wearing a mask, wearing gloves, etc. And at this point, if you are doing this, you might also just inform them that occupational health will be following up with them. If you're talking to them first and occupational health is calling them second, to tell them about their work schedule and if they can come to work or be off work. Or occupational health will have this whole conversation with them either. So it just depends on what's going on at your organization and flow. And then lastly, before you hang up, reconfirm the contact information, provide a summary, restate recommendations, and then provide them with next step. If the organization is going to follow up with them, if public health will be following up with them, depending on the pathogens, such as if this was a contact trace for Mpox that you're conducting at your facility, letting them know like, hey, public health might be following up to ask you some more questions about it too. Always getting that information. And then with all this information that you are doing, you want to collect it in a centralized database. So in your EMR system, you can pull reports and then save them. And keeping this documentation of who's exposed, how they've answered the questions, how you've determined if they have met the criteria or not, next step, i.e. providing testing, isolation recommendation, that should be all documented and saved in one central location. If your system doesn't have an automatically generated portal where this information is saved and accessed, you can always, when in doubt, start a spreadsheet. It's a great, easy tool. You can encrypt it, you can lock it, which is very, very important to do. And here's just an example of a spreadsheet that I created and how I set out. I encrypt them, I lock them on I have multiple tabs. So my first tab is always the just brief overview of what's happened, date and time, units involved, what specific organism I'm looking at, kind of just a brief summary. And then I have a tab for my staff and I have a tab for a patient. This is just how I have done contact tracing. That has been really nice, that it's all kept in one area and it's a big document. Feel free to modify it how you see fit, or if a different methodology works for you, but this is just one recommendation. So then this is just this is some of the information that I create on each of those tabs. So now we're in the staff tab, and the first column is your name, department and title, where they were and what unit they were on, date of contact, exposure duration, it's whole shift, 10 seconds, 5 minutes, maybe they're another staff member, but not the primary staff member, but the primary staff member needed help with the patient, such as like rolling or turning the patient, or maybe they were on break and someone was covering for them. So definitely knowing the duration and the relationship of the title and the department is very crucial. PPE worn, yes and no, and then what PPE type, vaccination status, testing is the next one, and then if isolation quarantine is needed, occupational health will be able to tell you that information. If they're allowed to work, not allowed to work, that's under their purview and their call. Your role in this part is just to disseminate that information to the staff. And then next you have your patient exposure contact trace. It's a little bit different. You have their names, their MRN, their date of birth, admit date, exposure date, unit, discharge date, duration, close contact. So it's a little bit different. You're collecting a little bit different information, and you'll also be asking a little bit different questions. Most of the time, you see that PPE isn't on here. If they are admitted to the hospital, they're probably not wearing other PPE, maybe a mask. But that's definitely something that you could ask when you talk to them as well. But it's highly unlikely they're wearing gowns or gloves as other patients in the hospital. So as we've talked about, contact is very essential for rapidly identifying who's been potentially exposed to really reduce the spread of the infectious organism. It plays a critical role of really reducing the outbreak because you are containing it by identifying who's been exposed, getting them tested, and then isolating them per the recommendation. It's a very time-consuming process, but it really helps reduce the spread. So now we're going to go into our learning check to walk through kind of a case example of how you would do this. You can scan the QR code, but I do want to open it up. Is there any general questions so far before we go into our example? Again, this is recorded. You'll get the link to the recording in about a week along with the slides. They will be posted. You will have access to this so you can walk through and kind of see the different templates and what's on the spreadsheets later for your reference. So we'll now start with our learning activity. So if you attended the 207 infection prevention lecture, this will seem, if you can recall this, that we're using the same scenario, but we're doing this scenario a little bit different. So an 80-year-old male patient was brought in by ambulance from a skilled nursing home to the emergency department on 7/12/24 at 12 p.m. with chief complaint of shortness of breath, which began in the morning at 6 a.m. and progressively got worse in the last hour. So they were admitted from ED to ICU. Patient has been a resident of a skilled nursing facility for the last 12 months. They are admitted with a pacemaker and a chronic Foley catheter and past medical history of hypertension, hyperlipidemia, and chronic kidney disease. So that's just a brief background. Obviously, during an actual event, you will go through your ED notes and your triage and then look at the very detailed chief complaint note to obtain this information. Day one, they are admitted from ED to ICU. They're assigned a double occupant room. That means that they have a roommate. Cardiac worker is performed in ED. It's unremarkable. Chest x-ray is done in radiology. It's unremarkable. And then lab orders in ED and ICU. So they didn't go to the lab. Labs were drawn specifically in those units. However, they went from ED to ICU, but before they were admitted to ICU, they went over to radiology for some testing. Blood cultures, urine cultures were ordered on day 2. Okay, day 4 of admission. Patient's family members are visiting. So they have visitors and they are chatting with the primary nurse, and it becomes aware that the patient's family member mentions that they are a resident of a skilled nursing home called Sunrise Nursing Home. And that name the nurse recalls from a previous unit meeting, which is a known C. auris facility, or they've had a recent C. auris outbreak. So at this point, it's been 4 days, and then all of a sudden on day 4, we now begin to have a fever. So the patient now is symptomatic for a potential C. auris event, and they come from a known C. auris facility. So the nurse is very concerned and calls infection prevention department for guidance. So the first question is this concerning? A, yes. B, no. C, depends on a few factors, or D, we're not sure. And I encourage you all to put your answers in the chat to try to make this more interactive. Everyone have their answers in? Right, yes. It is A, this is concerning. So if we recall from our previous module in 208, which was titled Emerging Pathogens, we talked about C. auris, and we mentioned how highly transmissible this pathogen was. Individuals require enhanced barrier precautions, which includes gown, gloves, masks when performing respiratory procedures. They should be in a single patient occupant room. They need to be specifically cleaned, all that material with EPA List P products. And then it's also a requirement to report to the local public health department within 1 day of a positive test result, since they will do serology on the specific pathogen. So day 4, now that we are concerned, after the nurse calls us and says, I'm concerned, they come from a C. auris facility, they're now fever, we have blood cultures, but I haven't had results. Our first step is to initiate infection prevention and control isolation measures while we await for the cultures. And then at this time, the roommate now becomes positive as well, or becomes not positive, symptomatic, with now they're having a fever of 108. So now we're ordering new blood cultures and urine on the roommate. Isolation measures are implemented on them. And then we're also confirming our disinfection protocol and making sure that we're using the right products. Day 5, more individuals on the unit specifically become positive. We do the same. Day 6, 3 additional patients on the ICU become fevered, and now on day 7, the index patient becomes C. auris positive. So now we have confirmed and verified our diagnosis with that test result. So now we know in the outbreak response, they will continue, someone else in the department will continue on with step 4, 5, and 6 through 11. We will now start the contact trace. And by we mean another individual within the healthcare facility, another infection preventionist will start the contact trace to identify other patients and staff that have been exposed during this time where infection prevention and control isolation measures were not implemented. So now we know that there is an outbreak. We have multiple people in our ICU that are symptomatic with C. auris. So now we will start the contact trace to potentially identify who has been exposed to reduce the transmission and reduce the spread so that we're not having more individual patients be positive due to lack of infection prevention and control measures not being implemented, and we don't have staff exposing other patients and carrying it to other patients because they've been exposed themselves and it's on their scrubs. So 2, question 2, do I report a positive culture to? Who do I report a positive culture to? Is it my organization, the local health department, both my organization, or the local health department, or no one? It's not important. So the answer is C, both your organization and your local health department. So you always want to, like I've mentioned in previous modules, you always want to make sure that there is clear, consistent communication within the organizational level of, hey, you're letting your leadership know what is going on. You're also talking to other players, since now this is an outbreak event. We're doing a contact trace. We're more likely going to be testing more patients and more healthcare providers during this time. You're also letting lab know that they will see an influx of these test results as well, confirming with them that you have the testing material to perform the testing and kind of what next steps are as well. Okay. So then on day 8, you have one more patient. Patients 3 to 4 are C. auris positive. Day 9, you have patients 5 to 7 that are C. auris positive. And day 10, you have day 10 to 14, you have patients 8 through 10 are C. auris positive. So you have different timelines that the patients were symptomatic and now their test results, and all 10 patients now have been confirmed as C. auris positive. So at this point, you know what has gone on. This is just a quick review. You have an 80-year-old male that was brought in from ED to ICU from a known C. auris facility. They were admitted with a pacemaker, chronic Foley, past medical history, and then the index patient that started this outbreak event was positive on day 7 of admission. So our case findings already, we know that there was no screening for CORS done on admission, no questions asked about what facility that they were talking about, no isolations initiated. We do know that the patient was in multiple departments. They were from ED, radiology, and ICU before we even pull our data. Multiple items were used. Staff did not wear PPE because they weren't on isolation. And then we're unsure if EPA list P was used, but during the outbreak, then, you know, if you have this scenario, the best way to confirm if a certain product has been used or not, huddle with your environmental and service directors, managers, ask them what is their cleaning process, what has been cleaned, how has this room been cleaned, to see if they can confirm, yes, the product that they standard use is effective on a specific pathogen or isn't. So question 3, based on the organism's route of transmission, what PPE should we ask when we conduct our interviews of potential exposure? What PPE do we ask were you wearing? Is it a gown and gloves, gown, gloves, masks, mask with respiratory involvement, masks and gloves for this specific pathogen? Right? The answer is C, your gowns, gloves, and masks. So for this specific pathogen, what criteria are we going to use to determine if close contact has been made and what exposure looked like? So going back to how this organism is contracted, looking at that epidemiologic triad of infection, that relationship between the host, the agent, and the environment. How is it spread? Is it through physical contact, shared equipment, or shared same environment, or D, all the above? Yes, the answer is D, all of the above. Okay, after we've determined what our close contact criteria is, which plays into our exposure criteria, what is our next step? Do we trace the patient, identify potentially exposed staff, identify potentially exposed patients, or D, all the above? So the next step is, this is kind of a tricky question. The next step is A, we trace patient's location, because based on that will tell us our patient and staff exposure, but D is also an appropriate answer too. Okay, so this is our, we have now traced and pulled data of what specific healthcare workers have been in contact or opened up to the chart. And it pulls these 13 names during this time of infection prevention and control measures weren't implemented. So you can see the name, the location, the title, and then the date of contact. So it follows when the patient was kind of there. So what is our next step? Ordering testing, interview staff to determine exposure, recommend isolation or quarantine procedures, or D, nothing. The answer is B, interview staff to determine if exposure, because you'll need to talk to them to be able to determine if ordering testing is recommended, and therefore isolation and quarantine procedures are recommended. So now here is your spreadsheet of your 13 staff that you have interviewed. So you have called every single individual and you've asked all the information above: exposure duration, close contact, if PPE was worn, PPE type, vaccination status. We put NA since for CORS for this specific pathogen, it does not come into play. Based on this information shown on the spreadsheet that you have collected, how many staff are you going to recommend to perform testing due to meeting that criteria of being exposed to this patient? Is it A, 3, B, 4, C2, D0. So the correct answer is 3, based on the yellow that you can see. The yellow individuals weren't wearing complete PPE that put them at risk for potential exposure. They were the individuals that were not wearing gown, gloves, and masks. They were just wearing masks. So those are the 3 individuals out of the 13 you're going to recommend get tested for C. auris. And then also occupational health is going to recommend if they should be at work, not at work, if they during this process as well. That's under their purview. They will make those recommendations. So then you will repeat this process on the patient side now that all the staff are done. So you'll pull the data from the EMR to see what patients came into contact. So here is, and these are other patients, not the 10 patients that were positive already. So this is an additional 10 patients that had close contact, and you're interviewing them. So you can either ask the nursing staff that are at the bedside to interview them if they're still inpatient, or if they've discharged, call them, or you can interview them yourself. So this is that information, the 10 patients that had close contact during this day, and you can see under close contact is they were in the same ED bay, they were in the same patient room, shared same equipment, same nurse, those providers. So based on this information, how many patients should we test? Is it A7, B8, C9, or D10? Right, it's 10. We're going to test all 10 patients based because they have met some point of that criteria of that shared environment that puts them at risk. Also, to bring to light, these patients are admitted in the hospital. There is a reason why they're there, the most likely immune compromised, hence sick, since they're in the hospital. So that's another indication that you want to test them, that these are all immune compromised individuals, not immune competent individuals. So then here is that spreadsheet with additional information, symptom dates, when they were having it, days that you ordered the test, their test result, and additional information that would potentially are risk factors. So based on staff and patients, how many people were tested for this specific outbreak or contact trace event? Was it 10? Was it 13? Was it 15? Or was it 20? Right, it was 13. So we had 3 staff members that were tested specifically on this outbreak event, and then we had 10 patients. And this is really a low number of what could happen. Sometimes during outbreak events or exposure events, you are testing 20, 30, 40, 50 people, depending on the size of the outbreak event. With that specific pathogen and the route of transmission of that pathogen. So that's why it's so important to talk with lab first and the organization what the cost is. Do we have the supplies? Do we need to set up a testing clinic? If it's such a big outbreak event, do we need to have like a special testing site? Who covers it? When you're talking about just a few tests, that's minimal cost, but when you're starting to test 30, 40, 50, 60 people, and depending on what type of test that you require to test them, if this is PCR, if this is serology, if they need a 2-step confirmation test, all of that goes into play during these events. So these are all questions that you want to have at the beginning with your leadership, with the organizational leadership, with the lab to make sure that this is doable. And then also with the nursing staff too, because they'll have to, perform some of the testing too, and it affects their workflow. So having this clear conversation of that there is an outbreak, these individuals have been identified, these patients have been identified, we're providing testing for them, these are the steps, they're on isolation, we're requiring that. It's really key to help reducing the spread of infection and making it go as smoothly as possible. So while you are waiting for test results, you want to circle back and communicate this information to your organization, maintaining HIPAA, who needs to know. And then also telling this to public health to see if additional action is required. Be transparent with them, tell them what's going on. They can provide recommendations and support. Next step, you need to let them know, especially if this is a pathogen that you need to report, and is a more emergent or rare pathogen, that they kind of already know that there has been an outbreak and that they are expected to see, 5, 10, 20, 30 cases of a specific pathogen from this organization. Can also help manage lab staff flow as well. So with this one, with CRs, you'll also be sending additional swabs for genetic sequencing for their requirement. You'll also be confirming and aligning that what you're telling them is same when they get discharged home. You are responsible for them in your healthcare facility, but they are getting discharged home. What type of public health actions need to be taken? Is public health going to follow up with them? What are next steps? So making sure that you're having that conversation with our public health partners during the time will really make it more successful. There will be more concise, clear, and consistent information, and there'll be a lack of disinformation to really help build that public trust in science and public health measures. And that will apply for both for staff and patients too. So lastly, how can contact trace and outbreak events be prevented? Is it hand hygiene, early detection of infectious agents, implementing good infection prevention practices, or D, all the above? Right, that is D, all the above. Hand hygiene is the #1 way to reduce infections, decrease transmission of infectious organisms, identifying what infectious agent is around so that we know what infection prevention and control practices that we can implement to reduce the spread, to really ensure that there is safety for our patients and our staff. So here's our answers. Again, for the questions on the slide deck for you to review later. And then lastly, just as a wrap up, although that contact trace is a very time consuming process, it is very vital to establish effective infection prevention and control practices that really reduce the spread of the transmission of the infectious agent. It is a critical role and component of outbreak investigations and exposure events. So make sure that you do your outbreak investigation workup, and then you're also having someone do your contact trace as well, so that we know who is all positive, who's been exposed, and then identifying if they need isolation, testing, or treatment. So lastly, we ask you guys to connect with us. As I mentioned at the beginning of this lecture, thank you guys for being flexible with moving platforms. Going forward, we are going to be on Teams, so if you have registered for modules 209 and 210, you will have to re-register. So be on the lookout for email notification, social media information about how to re-register and with the link. And we ask you guys to connect with us with our IPC email or general information. If you have any questions, feel free to reach out to us. We're more than happy to answer them and give you guys support. As I mentioned, all modules from last year's module 101 through 105 have been approved, and modules 201 to our upcoming to 210 have all been approved for 1 hour of CPH credit. The below modules have been approved for 1 hour of continuing education if you hold a CIC through CBIC. And the steps to obtain your education hours are in the slide deck. So within a week, when you get the link to today's recording along with the slide deck, you will see step-by-step instructions how to go on and complete the evaluations and the continuing education requirements to obtain your certificate that will be emailed to you. So lastly, we have our module 209. our next month module, which is infection prevention and control collaborations. We'll talk about infection prevention department collaborate, describe and explain how to obtain stakeholder buy-in and support, which is sometimes a challenge of getting to know why and how to implement infection control measures within your facility when it comes to a new policy, procedure, protocol, changing culture, and discuss approaches how to obtain this support and buy-in. We ask you all to complete the post-survey evaluation, which the QR code is right here. That information is really crucial to us. Based on your response, we take that information to build out the next lecture series. We want to make sure that you're getting what you're coming here for when it specifically involves infection prevention and control measures in healthcare settings. If you complete the post-survey evaluation, there is an opportunity for you to enter your email in to potentially win some Techie merchandise and swag that will be emailed to you as a thank you for completing that specific module. And then again, I just want to thank you all for coming today. We'll open it up for questions. We have our Techie Organizational Summit coming on September 25th. It is free. You can go on and register. It's an in-person and virtual event that looks at specific preparing for zoonotic health risks within our community. And then this is the page for the continuing education, which this will be emailed to you that you can provide step-by-step instructions. So just reminder that module 209 is next month in October. If you have registered for it, you will need to re-register for it. And same with 210. And we just thank you for coming today to today's lecture, switching platform at the last minute. And now I'll open up for any specific questions.
There is one question saying, how do you recommend not having recall bias or blending one case with others and getting confused on details if you can write things down right away?
So sometimes to have a very clear idea of what specific case you are, write yourself a little script that you're going to be talking to the patient or healthcare staff when you're interviewing them, that, you know, it's this patient, these are the dates, this is what they were admitted for, reviewing their record, so that you don't have recall bias, you know specifically, and you're clear and concise, you know, writing down close contact is defined as XYZ. So writing yourself a little script to help reduce recall bias when it's yourself. When you're interviewing someone to help reduce recall bias for them, try to ask them the same question a couple different ways to show that there's consistent response for them. And then kind of, you know, ask them more about the patient if they're having a hard time remembering them. When in doubt, if you are concerned and you're not quite sure if they've met the definition of exposure, I always like to lean on the side of caution and test them anyways. If they're not able to give me a clear explanation or recall what has happened and if they had contact with that, it's easier to test them prematurely and that be negative compared to waiting a few days. They've actually been exposed, but they weren't able to clearly communicate to you, and then you have a secondary spread of the pathogen. Does that answer your question?
And there's someone else asking to see the answer sheet again.
Here you go.
And then, what would happen if the index patient had passed away on day 4?
So if the index patient had passed at the day 4, they would still, so then you would have to follow up with the mortuary that the patient was at, letting them know, hey, this patient was infected. talking to them too, because the coroner will release the body. If later, because we did blood cultures on day 2, but it took, Candida auris is a slow growing, it's a yeast, it takes a while. So they, in this scenario, they passed away on day 4. But we still had those cultures. So definitely at that point, making sure that those cultures still, first, if that patient has died, confirming with the lab that they're still running the cultures is the first step. So even though that the potential patient or index patient has passed away, confirm with the lab, hey, can you please still run those cultures for me? And then the next step is then if that culture comes up after they're deceased, you're letting the mortuary know, handling the body, there needs to be taken additional steps, and you can talk to them. You can also let health know of, hey, there's this patient at mortuary X, they were confirmed with this, it has been passed away. You're still going to have to do your contact trace because there's still 4 days that they haven't had an infection prevention protocols initiated, so you're still going to have to test those other living patients and staff. But great question. That sometimes happens. Any other questions? Any other questions, Susie?
Oh, sorry, no. Oh, wait, one just popped up. Who usually funds the contact tracing?
Funding the contact trace is part of your infection prevention and control job. The testing is up to your organization. So you'll still have to do this. This is part of your job as an infection prevention practitioner, that you're doing these things internally. When there is an outbreak event, if testing is required, that's a conversation you need to be having at your organization level with your leadership, and also with public health, of what are next steps to provide testing to these people that have met the definition and that require it.
Those are all the questions.
All right. Well, thank you everyone for tuning in. We look forward to seeing you in October, and thank you again for your flexibility to be able to switch platforms. Please reach out to us if you have any questions. And I hope you all have a great rest of the day.